So what are the factors that are associated with mouth breathing during sleep? Well, mouth breathing during sleep leads to a very poor quality of sleep. A number of factors associated with it include when you breathe through an open mouth, you're likely to dry out the upper airways, and as moisture is sucked out of the upper airways, it contributes to inflammation. Dryness of the upper airways also contributes to stickiness, that if you do have an event in that if your airways do collapse, they will remain collapsed for a lot longer before they reopen because the airways are sticky. Another aspect associated with mouth breathing is that mouth breathing activates the use of the upper chest muscles more than the diaphragm. And as a result, it reduces lung volume. And with a reduction to lung volume, the upper airway dilator muscles don't work as effectively as they should do. Mouth breathing is bypassing the nose, so you don't get the benefits of nasal nitric oxide. Nitric oxide from the nose is 50 to 200 parts per billion, and nitric oxide from the mouth is 10 parts per billion. Nitric oxide is an aerocrine messenger that sends signals to the upper airway dilator muscles to do their job more effectively. It's also a bronchodilator. If we have constriction to the lower airways, that in turn can contribute to constriction and stuffiness of the nose. Reduced ventilation perfusion. This too relates to nitric oxide in that when we breathe through the nose, nitric oxide helps to redistribute the blood throughout the lungs. Nasal breathing also helps to redistribute air throughout the lungs. So in other words, that the ratio of air meeting blood is higher. This improves what's called ventilation perfusion, and this in turn leads to an improvement of oxygen uptake in the blood by between 10 and 15%. Mouth breathing causes and contributes to decreased end-tidal CO2. End-tidal CO2 is the carbon dioxide that's in the lungs that gives you a good approximation of the carbon dioxide in the blood. In other words, that the neural drive to breathe is carbon dioxide. Carbon dioxide is the primary stimulus to breathe. If we are mouth breathing and we're breathing too hard and we're getting rid of too much carbon dioxide from the blood through the lungs, the neural drive to breathe is impacted. Mouth breathing also leads to an increased ventilatory response to carbon dioxide. In other words, that individuals then have an exaggerated response to the accumulation of CO2. In terms of phenotypes of obstructive sleep apnea, this would be referred to as high loop gain, and mouth breathing leads to lighter sleep. Conversely, the benefits of nasal breathing: more moist upper and lower airways, less likely to be inflamed. There's reduced stickiness of the upper airways due to the moisture content there. When you sleep with an open mouth, you wake up with a dry mouth in the morning. When you sleep with your mouth closed and you're breathing in and out through your nose, your mouth is more likely to be moist when you wake up. Nasal breathing activates the diaphragm more effectively than mouth breathing. An improvement to lung volume as a result of diaphragmatic movement leads to better functioning of the upper airway dilator muscles. Nasal breathing is harnessing nasal nitric oxide, and I spoke about the benefits of that just a few minutes ago. Those benefits include messaging to the upper airway dilator muscles, improved ventilation perfusion. Nasal breathing also leads to improved or more normal end-tidal CO2, and as carbon dioxide is the stimulus to breathe, having more normal CO2 means that you have more regular breathing. Breathing through your nose both during wakefulness and sleep, that you have a more normal ventilatory response to carbon dioxide. In other words, you don't have an oversensitivity to the gas. If you have an oversensitivity to the accumulation of CO2, it causes very unstable breathing during sleep, and this feeds back into sleep problems, including obstructive sleep apnea. Nasal breathing is paramount for having a deep sleep. So when we look at sleep disorder breathing, snoring is the first thing that comes to mind. Snoring is noisy breathing during sleep, and it's caused by the exchange of a large volume of air through a narrowed space, which in turn causes the tissues of the nose and the throat to vibrate. There are two aspects here. Number one is that the individual is breathing hard, and number two is that the airway can be compromised. Doctors traditionally, when they are investigating snoring, will look at the airway. We must also look at flow. The amount of air that you're breathing through your airway will also contribute to turbulence. It's not just about an airway, it's not just about breathing, It's about both combined. Mouth snoring is when there's vibration of the soft palate. It's very easy to address mouth snoring. One of the strategies that we use is simple paper tape across the lips. As soon as your lips are closed, sealed with paper tape, mouth snoring is eliminated. The second type of snoring is snoring in the nasopharynx. So there's turbulent airflow in the nasopharynx and oropharynx, and this in turn is causing inspiratory flow limitation. We also help with snoring in the nose, because we're helping to open up the nose, but we're also helping to normalize breathing volume. The next stage of sleep disorder breathing includes obstructive sleep apnea. During wakefulness, the airway is held open by the upper airway dilator muscles. But after the onset of sleep, when the muscle activity is reduced, the airway can be liable to collapse. Collapse of the upper airway, it occurs if the negative pressure created during breathing exceeds the dilating force of these upper airway dilating muscles. So when we consider collapse of the upper airways, we need to consider two factors. One is how much pressure is created during inspiration. As you're sucking air into your lungs, if you're breathing hard and fast, you increase the negative pressure. And number two is the ability of the upper airway dilating muscles to withstand that suction pressure. With breathing re-education, we can target the amount of suction pressure that's created by changing breathing. We can also, by breathing re-education, influence the functioning of the upper airway dilating muscles. And obstructive sleep apnea, it's a common disorder of repetitive pharyngeal collapse during sleep. Pharyngeal collapse, it can be complete, causing what's called an apnea. So basically an apnea is when we stop breathing for periods of 10 seconds or more. Or a partial collapse of the airway is a hypopnea. A hypopnea is when there's a restriction to the flow of breathing. Disturbances in gas exchange lead to oxygen desaturation, hypercapnia, and sleep fragmentation. So if you have an apnea and you stop breathing for a period of time, your blood oxygen saturation decreases because your cells continue to extract oxygen, but you're not replenishing it through breathing. At the same time, carbon dioxide is increasing in the blood because it's not able to leave the body through the lungs. So during either an apnea or a hypopnea, blood oxygen saturation is dropping. At the same time, carbon dioxide is increasing and we experience sleep fragmentation. So sleep fragmentation means that our sleep is being disrupted. We're no longer staying in the deep stages of sleep, that we're waking out of sleep. We might not wake up consciously, but we are taken from the deeper stages of sleep to more lighter stages. These contribute to the consequences of obstructive sleep apnea, which affect the cardiovascular system, metabolic, and also have neurocognitive effects. The best test for obstructive sleep apnea is overnight polysomnography in a laboratory, with the primary outcome measure is the apnea-hypopnea index, which is the number of apneas plus hypopneas per hour of sleep. Breathing stoppages are apneas. Periods of reduced airflow are a hypopnea. They're lasting for 10 seconds that result in a brief awakening and arousal or reduced oxygen that occur per hour of sleep. The index is, for adults, mild sleep apnea is typically defined as between 5 and 15 events, moderate is 15 to 30 events, and severe is more than 30 events per hour of sleep. For children, on the other hand, mild sleep apnea is any time that there's an event over one or more events per hour is a clinical diagnosis of obstructive sleep apnea. So the AHI for children is mild is 1 to 5, moderate is 5 to 10, and severe is 10 events plus. Obstructive sleep apnea is relatively common. For example, in this paper here, it affects 9% of women and 26% of men in the 30 to 49 years old category. But as we get older, obstructive sleep apnea remarkably increases. So there is a threefold increase in obstructive sleep apnea in women from the ages of 30 to 49 to 50 and 70. And in men, it increases from 26% to 43% in the same age category. However, most people with obstructive sleep apnea, they're undiagnosed and they are untreated. For example, the gold standard treatment of obstructive sleep apnea is a CPAP machine, and CPAP stands for continuous positive airway pressure. The idea, it came from a Dr. Colin O'Sullivan who invented the device. He got the idea from a vacuum cleaner. A vacuum cleaner sucks air, but a CPAP machine does the opposite. It pumps air. The individual wears a mask, and there is a unit which is administering air at a force that's sufficient to splint open the airways. The wearer will often find that it's uncomfortable. It dries out the upper airways. They get entangled in the hose. The mask has to exert a considerable pressure against the face, otherwise there's leakage. But the pressure that's exerted by the mask on the face can also cause retraction of the jaws. So it can lead to a change in facial structure and thereby reduce airway size. Many individuals who are prescribed the CPAP machine, number one is that they don't take it on, and number two is 50% of people abandon it after about 6 months. I was recently in California and I got a lift with an Uber driver, and during the course of our conversation obstructive sleep apnea came up. The Uber driver told me that yes, he's feeling tired. He's feeling tired upon awakening. His wife has told him that he's stopping breathing during sleep, so he went to have his sleep investigated. He walked into the sleep study, and upon walking in he was requested to fill out a form. In the form it stated that if you have a positive diagnosis for sleep apnea, the car licensing authorities will be notified. So as soon as he read this, he turned right around and walked straight back out of the clinic. So in other words, the concern that his driver's license will be revoked was enough to propel him not to continue. So now you think that you have a driver that's full-time driver, driving people around, and he doesn't have the full concentration, the full energy and the full focus that he should have. Car-related traffic accidents, up to 20% of them are down to driver fatigue, and many of those will be because of poor quality of sleep. Primary care physicians, they may not be prompted to explore an early diagnosis of obstructive sleep apnea. It's especially true if the patient doesn't present with sleepiness and a classical high body mass index. But not all patients with obstructive sleep apnea are sleepy, and not all of them are obese. For example, in this paper here, up to 50% of people with OSA are not obese, and 25% of individuals with moderate obstructive sleep apnea, in other words, they have an AHI of between 15 to 30 events per hour, which is significant. They have neither subjective nor objective sleepiness. Obstructive sleep apnea is also a little bit of a vicious circle. It is true that as we add on weight, that it increases the risk of obstructive sleep apnea. And one of the things about obstructive sleep apnea is that it can affect hormones. Leptin and ghrelin are two hormones that have been recognized to play a major influence on energy balance. Leptin is a mediator of long-term regulation of energy balance. It suppresses food intake and thereby induces weight loss. But ghrelin, on the other hand, it plays a role in meal initiation. So you have leptin, which is suppressing food intake, and ghrelin, which is promoting food intake. There is increased levels of ghrelin in patients with obstructive sleep apnea. So these individuals who have a tendency towards increased obesity, with increased obesity there's fat deposits on the tongue, so the tongue is larger, so it occupies more space and thereby reduces airway size. At the same time, fat deposits in the throat are reducing airway size. Third factor is that there's fat deposits on the belly, and this prevents proper diaphragmatic functioning. When the diaphragm doesn't function properly, the upper airway dilator muscles aren't receiving the input and they're not doing their job effectively in keeping the airway open. After a 6-month treatment period with CPAP machine, there's a significant drop in ghrelin levels could be observed, and this is showing that obstructive sleep apnea is a vicious circle. Individuals presenting with obesity who were experiencing obstructive sleep apnea, during their sleep their hormones are affected, which is increasing their food intake, which in turn is increasing their obesity, which in turn is increasing the risk of obstructive sleep apnea. Mouth versus nose. We went through a summary at the very start. Now I'm going to go into a little bit more detail. It's not new information. but the nose plays a major role in the regulation of respiration in sleep. I always say to my clients coming in, if you wake up with a dry mouth in the morning, you are not having a good night's sleep. The earliest accounts of the deleterious effects of mouth breathing in sleep was made by Levinus towards the end of the 16th century. There is a twofold increase in upper airway resistance during sleep while breathing through the mouth. Now, it is true that your nose imposes a resistance that's 2 to 3 times that of your mouth during the day. So by breathing through your nose, because your nostrils are narrow and the air is being swirled by turbulence in the nasal cavity, is purposely designed to slow down the breath. So nose breathing during the day does impose a resistance, but this is positive. However, during sleep, the opposite happens. The resistance by mouth breathing is 2 to 3 times that of the nose. During sleep, you don't want a resistance to your breathing. Lung volume is another issue. We spoke about this, that in animals and man, the area of the upper airway increases when lung volume increases. Having a good defined airway in the upper airway is beneficial because if there's an increase in airway diameter, there's a reduction to the negative pressure during inspiration. Conversely, the airway is smaller and collapses more easily when lung volume is small. The relationship probably exists because the lower and upper airways are mechanically linked. So with increased lung volume, there's a stiffening and dilation of the pharyngeal airway. So the throat stiffens and dilates when we're using our diaphragm. There's a correlation existing between the amplitude of diaphragmatic movement during tidal breathing and lung volume. If you want to improve your lung volume, we have to ensure diaphragmatic breathing. But if we want to use our diaphragm, we have to ensure nasal breathing. Your nose is linked to your diaphragm and your diaphragm is linked to the upper airway dilator muscles. In this study, 28 subjects, mouth open or closed. Open mouth breathing is associated with a reduction of the retropalatal and retroglossal areas. In this paper here, you see a visual of the pharyngeal airway dimension, that it's much higher in nasal breathers than in mouth breathers. For example, the area in this instance with mouth breathing, it was 5,000, and with nasal breathing, it was almost double. In this paper here, 27 children, 15 mouth breathing children and 12 nasal breathing children aged between 7 and 14 years. As compared to nose breathing children, mouth breathers were more likely to snore and to have an AHI greater than 1. Mouth breathing children were also more likely to have a retruded mandible, more inclined occlusal and mandibular planes, a smaller airway space, and a smaller superior pharyngeal airway space. So when we're looking at obstructive sleep apnea, we have to consider the size of the airway and flow. If there is a reduction to the size of the airway, the negative pressure created during inspiration increases, thereby increasing the collapse of the upper airway. The AHI index increases as the posterior airway space decreases. According to these researchers, orthodontists should send any mouth-breathing child for an evaluation of sleep if they find that the child has a small superior pharyngeal airway space. For me, dentists have a huge role to play in sleep, and the reason being is this. Dentists see their patients very frequently. Dentists are looking into the mouth. Dentists are often taking scans of the airways. They're using Ceph. And they're in such a wonderful position to be able to identify a high risk of sleep disorder breathing, both in children and in adults. And what's more, dentists are also in a wonderful position to be able to do something about it, especially in children, whereby the growth of the face can be directed by virtue of appliances and restoring nasal breathing. The muscle activity of the upper airways is higher during nasal breathing than during mouth breathing. The muscles work harder when breathing is through the nose than through the mouth. The nasal route for inhalation, it may provide important afferent input to protect the upper airways from collapse. There is a marked reduction in upper airway dilator muscle activation when breathing via tracheostomy as compared to normal. Another factor that we looked at is end-tidal CO2. Carbon dioxide is the drive to breathe. end-tidal CO2 is significantly higher during nose than mouth breathing. It suggested that a loss of nasal functions, so if the nose is stuffy, the individual breathes through an open mouth, and this may result in lowering of CO2, which will foster apneic events during sleep. The upper airway dilator muscle also receives respiratory input. So in other words, hypocapnia, which is too low CO2. It's not just changing the neural drive to breathe, but actually the upper airway dilator muscle is also receiving input as a result of blood gases. The loss of carbon dioxide reduces the activity of the upper airway dilator muscles, and this could cause collapse of the airway. This is a very interesting study. It was published back in 1981, and it was investigating the effect of acute nasal obstruction on sleep and breathing in 8 normal persons. On one night, the persons studied with the nose open, and the second night, the persons were studied with their nose obstructed. Sleep proved to be subjectively and objectively disturbed. The nose obstructed awoke more often. They had a greater number of changes in sleep stage, and they spent a greater amount of time in stage 1 non-REM sleep, in other words, in light sleep. Acute nasal obstruction caused a statistically significant increase in the number of partial and total obstructive respiratory events, both obstructive hypopnea and obstructive apneas. Nasal obstruction caused a statistically significant increase in the AHI, and sleep apnea developed in one subject during this study merely on the basis of acute nasal obstruction. And of course, it's not necessarily the nasal obstruction, but it's the nasal obstruction which is resulting in mouth breathing, which in turn is leading to a light sleep. In this paper, 10 normal men had full night recordings before and during nasal obstruction. During nasal obstruction, the time spent in deep sleep stages reduced from 90 to 71 minutes, whereas significantly more time is spent in stage 1 light sleep. There was a 2-fold increase in sleep arousals and awakening resulting from an increased number of apneas. For example, 34 during controlled sleep, but 86 during obstructed sleep. So when the nose was closed and the individuals were mouth breathing, their apneas more than doubled. Also, not only did the apneas double in instance, they also become more severe. For example, apneas of 20 seconds to 39 seconds in duration became 2.5 times more frequent when the nose was obstructed. Desaturation also occurred more frequently with a stuffy nose. So the SaO2 less than 90%, it occurred 27 times during controlled sleep, compared with 255 times during obstructed sleep. All men complained of poor sleep quality during nasal obstruction. Apneas, sleep arousals and awakenings, and the loss of deep sleep during nasal obstruction may explain the complaints of poor sleep quality. So breathing through an open mouth, it results in light sleep, and of course light sleep is going to play an impact on arousal threshold, which is one of the phenotypes of obstructive sleep apnea. If one has light sleep, one has a low arousal threshold, and having a low arousal threshold means that the propensity for you to wake up during sleep is quite increased. That it doesn't take much of an effort to breathing to take the individual from a deeper sleep to a lighter sleep. Arousal threshold is also an issue because it's related to an increase in mortality as a result of sleep disorder breathing. This paper here, data on nasal congestion, history and sleep problems were obtained by questionnaire, a population of 4,927 patients, and by objective in-laboratory measurement of 911 patients. Participants who reported nasal congestion due to allergy were 1.8 times more likely to have moderate to severe sleep disorder breathing than those without nasal congestion due to allergy. Another paper published by Fitzpatrick, during sleep, upper airway resistance was much higher while breathing through an open mouth. In addition, obstructive apneas and hypopneas were profoundly more frequent while breathing through the mouth. The AHI index was 43 events by mouth breathing versus 1.5 during nasal breathing. My comment on this paper is that it would be very difficult for us to reproduce those figures. You know, by switching individuals from mouth to nasal breathing, could we expect to bring the AHI down from 43 events to 1.5? I think there's no question that we can make a significant impact. And this next paper will give us some indication of that. This involves 30 patients. An AHI is mild, 5 to 15 events per hour. And they wore paper tape across their lips at night. Before the tape, the Epworth Sleep Scale was 8.1, but after it, it dropped to 5.2. The Visual Analog Scale was 7.5 before the tape and 2.4 post-tape. The median AHI reduced from 12 before the tape to 7.8 post-treatment. Now, this result is just by getting the mouth closed. But how also about normalizing breathing volume so that the individual is breathing lighter? Making sure that the tongue is resting in the roof of the mouth. Because in terms of correct resting posture, I learned nasal breathing back in 1998. But it was only when I met Karen Samuel, a myofunctional therapist in the United States in 2005. And during a course of conversation with her, I asked her, where's the correct tongue posture? And she said, well, it should be in the roof of the mouth. And I asked her, how much of the tongue should be in the roof of the mouth? And she said it was 3/4 of the tongue. So when we establish nasal breathing, and if we are wearing paper tape across our lips, we also need to make sure that we have correct resting tongue posture. It doesn't automatically happen when we switch from mouth to nose breathing. The tongue has got two places to be. It's either in the roof of the mouth, which is ideal, meaning that you're taking it out of the airway, or it's falling back into the throat. So with nasal breathing, correct resting tongue posture, normal breathing volume and diaphragmatic breathing, we can significantly improve and reduce the AHI index. The results in terms of research, I can understand why some researchers will say, or doctors will say, well, nasal obstruction doesn't play a whole role. This meta-analysis here, it looked at 9 trials. External nasal dilators, which are based on the Cottle maneuver, designed to help open up the nasal airway, were applied in 5 studies. Steroids in 1, nasal decongestants in 2, and surgical treatment in 1. The researchers, when they looked at the 9 studies, they concluded that chronic nasal obstruction seems to play a minor role in the pathogenesis of obstructive sleep apnea. But the real question to ask here is, during each study, even though the nose was treated, did it mean that the individuals were breathing through it? If you were investigating the effect of chronic nasal obstruction, we have to investigate, are the individuals breathing through their mouth or are they breathing through their nose? The fraction of time that individuals spend mouth breathing. Here's an interesting paper looking at 41 subjects, and they looked at each 30-second sleep epoch which wasn't affected by apneas or hypopneas. Overnight, out of 41, 7 subjects breathed nasally. 1 subject breathed both through the nose and through the mouth, but the remainder switched between nasal and oronasal. Oral breathing only rarely occurred. The key point here is that subjects over 40 years of age, they were approximately 6 times more likely than younger subjects to spend greater than 50% of their sleep epochs utilizing oronasal breathing. And of course, subjects over 40 years of age, we are at a higher risk of obstructive sleep apnea. Looking at another aspect of it is mandibular opening. The percentage of total sleep time spent with mandibular opening with the mouth open greater than 5 millimeters was significantly larger in patients with OSA, 69% compared with healthy subjects without OSA at 11%. Another factor to consider when we are looking at breathing is minute ventilation. How much air is the individual breathing per minute? And minute ventilation is a sum derived from counting the respiratory rate, which is the number of breaths per minute, multiplied by the tidal volume, which is the size or the volume of each breath. So the respiratory rate multiplied by the tidal volume gives you your minute ventilation. This paper here, 9 normal male volunteers 20 to 28 years of age. During a sleep study, they had 5.35 litres during nasal breathing and they had 4.92 during predominantly mouth breathing. Now, one would always suspect that mouth breathing leads to a higher minute ventilation, but it's not always the case. So you see from this paper here, individuals breathing through their nose, their minute ventilation was slightly higher than breathing through the mouth. But whether it was mouth or nose breathing, minute ventilation here was normal. In this paper here, minute ventilation is with mouth breathing is 8.43 and nose breathing is 9.37. With this paper here, the minute ventilation during wake was 10.6 and the minute ventilation during sleep was 9.2 litres. For women, it was 7.8 during wake and during sleep it was 7.2. This paper, 20 obese men with obstructive sleep apnea but with normal lung function, they were breathing 15 litres of air per minute. The second group studied were obese men with COPD and OSA. They had 12.8 litres. Normal minute ventilation is between 4 and 6 litres of air per minute. If one is breathing in excess of normal metabolic requirements, for example, a higher respiratory rate, larger tidal volume, higher minute ventilation, the increased breathing volume will increase the negative pressure in the airways. Some of the papers, especially the first one with normal subjects, we see that they are breathing 5 litres of air per minute. But other papers, it is not. It is ranging from 8 litres up as high as 15 litres of air per minute. If one is breathing in excess of metabolic requirements, it is important to normalise breathing volume in order to reduce the negative pressure created during inspiration. Because if you're breathing hard and fast, you're increasing resistance in the upper airways. I was always curious from an asthma point of view. Why, when asthma severity increased, so did obstructive sleep apnea? And obstructive sleep apnea and asthma, they're highly prevalent respiratory disorders. They're frequently comorbid. As I said in another presentation, individuals with asthma, they don't just have asthma. They are tired. They are more likely to snore. They are more likely to have obstructive sleep apnea, and they are more likely to be tired during the day. Undiagnosed or inadequately treated obstructive sleep apnea may adversely affect control of asthma and vice versa. For example, 88% of patients in severe asthma group, 58% of patients in moderate, and 31% of patients in controls without asthma had more than 15 apneic events per hour. So as asthma severity is increasing, so is obstructive sleep apnea. How might that be? Well, let's look at the breathing of somebody with asthma. They will often breathe through an open mouth because their nose is stuffy. They breathe faster and they breathe using their upper chest. They're not getting the benefits of nasal breathing. They're not harnessing nasal nitric oxide. Their end tidal CO2 can be lower. They're breathing using their upper chest, so they're not benefiting from breathing using the diaphragm. They're breathing hard and fast. So the nose is affected. The biomechanics of breathing is affected because they're using their upper chest. The biochemistry of breathing is affected because their CO2 levels are lower than normal, and also they're not harnessing nasal nitric oxide. So how do we help people with asthma? Well, any person coming into me with asthma, I would expect a 50% reduction to their symptoms in 2 weeks, a 50% reduction to wheezing, to coughing, to breathlessness, to chest tightness. How do we achieve that? We achieve that by switching from mouth to nasal breathing. We achieve that by normalizing breathing volume and by activating the diaphragm. By improving asthma, we also improve their sleep. And of course, because of the bidirectional relationship, by improving sleep, you're also helping to improve asthma. There's also an association between asthma and rhinitis. If there's inflammation in the nose, it will result in lower airway inflammation and vice versa. So inflammation in the lungs travels up to the nose, and inflammation in the nose travels down to the lungs. Inflammatory mediators and or infectious pathogens may be transported along the respiratory mucosa or through the airways. Nitric oxide and carbon dioxide may also act as an airborne messenger. Physiological, epidemiological and clinical evidence support a unified airway model. So when we're considering breathing, we have to consider what can we do to help with sleep. We know the 4 phenotypes of sleep apnea: picrit, the pharyngeal closing airway pressure, loop gain, the stability of your breathing during sleep, arousal threshold, the propensity to wake from sleep, upper airway recruitment, how well are the upper airways working effectively. So with the 4 phenotypes of sleep, it merges beautifully with breathing re-education. Why? Because when you change breathing patterns towards normal, there's a reduced negative pressure in the upper airways. You've got an enhanced concentration of nitric oxide. You've got improved ventilation perfusion. You've got more normal end-tidal CO2. You've got improved functioning of the nose. When we breathe through the nose works better. It's easier to maintain nasal breathing when we go through the exercise because the individual doesn't feel that feeling of suffocated. If you have a child or adult who has been persistently mouth breathing for a period of time, if you just say to them, breathe through your nose, they may feel suffocated because they have a breathing pattern disorder, they have an elevated respiratory rate, they're more thoracic breathing. So we need to teach them breathing re-education to help to normalize their breathing so that they can breathe through their nose without the feeling of suffocation. Nasal breathing and normal breathing volume, it reduces the ventilatory response to CO2. So all aspects in terms of sleep, if you are treating sleep, we have to treat breathing. Breathing is a fundamental aspect of sleep, and we have to be looking at the mode of breathing of the patient during their sleep. How we breathe during wakefulness will carry through to during sleep. We change breathing patterns during wakefulness, and that in turn will lead to improved breathing during sleep and a reduction of sleep disordered breathing.